My name is Dr. Robert Alexander from Stevensville in Hamilton, Montana. The path started a long time ago within the process of education. I decided that I wanted to do aesthetic reconstructive surgery. In order to do that in craniofacial surgery, I chose a path that led me to a dental degree and a medical degree at University of Florida. And from that point on in the residency training in trauma surgery and plastic and reconstructive surgery and all the processes that were involved with that aimed coming back to a focus on wound healing. Wound healing is as much a part of plastic surgery as it is regenerative medicine. Regenerative medicine has been a field that's expanded out to a wide degree now and growing rapidly of how we understand that to make our bodies maintain ourselves and get healed and how to close wounds or take care of surgical aspects. Wound healing is a critical and core issue amongst all of them. Once we found, largely through one of the founders of Tulip Medical, John Johnson, that he had an ability to get these access cells that were going to be important for wound healing and for reparative and regenerative medicine. All those things kind of fell into place, and the rest is kind of history. The use of the small cannulas, the advances that have been brought forward, being able to isolate these cells into small particles instead of the kind of bulky, less homogeneous tissues that are comprised of our fat. We've thrown millions of stem stromal cells away in the course of taking body contouring and doing all the things and augmenting, using it for grafting. The regenerative medicine then began to take effect when we found that these cells had the ability, probably in around year 2000 roughly, that the cells had capabilities of producing other kind of cells, being grown and form muscle, for example. They can produce smooth muscle, cardiac muscle, skeletal muscle, the tissues that it can do and become viable and repair things like torn or damaged ligaments or degenerative ligaments and tendons. Those have revolutionized the approach of a minimally invasive surgical aspect of how regenerative medicine works. I would say not really a revelation. The introduction into the liposuction or sculpting process started back in the early 80s, and at that time we were looking only at contouring and weight reduction and shape changes, etc. My first foot into the regenerative medicine side came in about 1992 when we began using platelet-rich plasma. The concentrating of our plasma, used it on tissues, noted that the tissues suddenly healed much faster, more vascular, more healthy. We were still doing the beginnings of fat grafting then, and because I had been a heavy user of platelet-rich plasma, I found that the addition of that to the adipose even did a better thing, because the adipose offsets the flare reaction, the reaction of inflammation suddenly turned on. The adipose nullifies that. And then kind of the rest is history. From that, it was natural, once we got an explanation of why that was, basically by Patricia Zook in the research when she decided to do the separate cells and what they could become, how they could be multipotent. At that time, then orthopedics began and sports medicine began to get into it. They didn't embrace it, sports medicine more than orthopedics, because orthopedics really felt like the surgery and the bones and plates and artificial joints were going to be the answer for the cure for arthritis. But in fact, it's a short cure. That it will take care of the arthritis in a joint that you replace. However, it won't take care of the structures that support and operate that artificial joint. That's where regenerative medicine really locked into me, and I said, not only are we going to have to deal with this adipose tissue and platelets together, but it's going to make a much better recipient bed for an artificial device, because there are times when surgery is critical and there's no options. A lot of times that's not true, and what we see now these days is many times patients have been told to have an artificial shoulder or knee or hip or something, when the indications were not encompassing and not very dramatic. That it just kind of was the last resort, that they just said, well, you're probably bone on bone, you're going to have something done, and you're going to have a total joint because we've tried everything else. everything else, it turns out, expanded into an entire field of regenerative musculoskeletal medicine. Some people call it orthobiologics. As you know, I call it biocellular for more than bone and joints. But that combination has led me to where we are today, doing a lot more research, trying to understand what we see when we deliver the products. And the grafting and the volumization and the things in plastic surgery is equally important to the changes that will occur when a tendon can regenerate or a ligament can be replaced. And the body, as it's aging, as it gradually ages more and more, it's a degenerative process that goes on. We can't really stop it. We can slow it, and we can certainly make it crawl, as we're learning nowadays. But that regenerative process gives us the ability to go out and harvest a structure using the own cells, the same cells that you use for repairing every other tissue in the body. And it's at work in us from the moment of conception until we are no more. And that is going to be a lifelong advantage. The cells that adipose turns out, unbeknownst to many of us, outlives and outperforms bone marrow because bone marrows begin to shut down at about age 50, 55. Can't use it in leukemias, lymphomas anymore because that's just not productive. The adipocytes of the precursor cells that are found within them around the blood vessels, etc., will go on well into the 90s, and so they retain the ability. So the fact that we started to describe the component parts of SVF. For many years, people have talked about stromal vascular fraction without a definition. Yes. It's an amorphous term that really says stroma, which means it's the supportive scaffolding. It is vascular, coming around the blood vessels where most of them are, or in the matrix within the body, this extracellular matrix. And so that's how the differentiation between tissue SVF came about, which by definition, tissue SVF is the same as lipoaspirant, whether it's through your microcannulas or large cannulas. That's still tissue SVF. It's all the components combined that come out together. Cellular SVF has other applications and potentials, and those potentials are in the way of doing intravascular, interarterial, infusion type of injections. What you cannot use the tissue SVF because it has fibrous material in the clumps that cannot be placed to a vein or an artery or in any real location without a chance of having clotting or blockage. And so the cellular SVF, when people ask me about SVF, I try and which SVF are you talking about? Because then they're still at that point, and we're making progress because I'm getting questions now during the educational times and when we have training seminars. We're starting to get the questions of that, well, I'm doing a tissue SVF, and then from that you need to break it down even further. The breakdown is, are you using it as is through a microcannula or a big cannula? That's one size particle. If you do it through anaerobic transfers back and forth where we're partially emulsifying, that's another animal. And you've got to tell me, is this partially emulsified tissue SVF? And finally, then through the creation of what's now known as nanofat. And that's where it's gone through the same process to partially emulsify, then going through a grid, offset grid wire that takes out the adipocytes, which are not really desired because we want the small cells that are attached on the blood vessels, the extracellular matrix, as the predominant cell. And we can concentrate and augment cell enrich by using nanofat with tissue SVF. That's still not cellular SVF. Cellular SVF has to be disassociated. That can't be done by vibration. They've tried the multiple ways of trying to break it loose and doing all kinds of gymnastics. Those cells are bonded and adhered. The only way is to break those bonds through the use of digestive enzymes at this point in time, and that's gaining more momentum through clinical trials especially, and that the idea of breaking those cells loose, the concern was, FDA had concern of two things. They're interested in how safe is it, and then does any of it work? Well, the answers are coming in rapidly. The safety profile of using the cellular SVF is phenomenal. I mean, I'm over 1,000 of cases and not a single adverse event to report or severe adverse event from the use. So it tells me that because it's also having effects on things like the COPD and COVID lung, that there's a place for this and there's a reason why that works. Those cells have anti-inflammatory capabilities, immune modulation capabilities, and will quiet a sign in an area of destruction and scarification, if you wish.